Right, technique. So we've talked about why and some evidence behind it, and now we're shifting towards technique. So ISR, we had a case earlier on, and as I said, the technique is very different in ISR. You're within the curve of a stent, so you go aggressive as much as you can. You try and get the best luminal gain you can during ISR, and then DCB only to deliver the drug. De novo is very different kettle of fish. You have to be patient, you have to be gentle. We have to come out slightly from our stent era mentality to deal with de novo disease if you want to treat them with DCBs eventually. So I don't predilate with semi-compliant balloons anymore. I go straight to NC balloons. If there's dog boning, there's high pressure in the edges of a semi-compliant balloon that can cause dissections that are vessel-threatening. But whereas in an NC balloon, usually the pressure is distributed equally, so you don't get that many dissections as long as you're within relatively lower pressures. So all we need is fully inflated balloon. So 6, 8, 10, whatever the atmosphere that needed just to get the balloon fully opened. That's what we would aim for. And you can keep the balloon inflated for a little longer than what we do with stent implantation, not the quick up and then down, just keep it for about 10 seconds. That's how you get the balloon angioplasty result. And then long inflations, if there's recoil, you can keep up to 1 minute or if not more, if the patient is tolerating. If there's less than 30% recoil, no major dissections, TIMI-3 flow, you can accept that as an optimal balloon angioplasty result. If there's more than 30% recoil, long inflation, you can use scoring cutting balloons and high pressures only if there's resistant recoil. Don't forget your patient. Is he or she having chest pain? Are there any ECG changes? Is the blood pressure okay? Then you take the check angiogram, a lot of GTN, long acquisition. That's really important. We are used to taking short acquisitions, but with DCBs, you need to take long acquisition. Make sure if you have the foot pedal with you, keep it on for a little longer. If the radiographer is taking, ask him or her to keep the foot pedal a little longer. We need to make sure we acquire at least 2-3 seconds after the dye has cleared. That's the only way we would detect contrast hanging in a major dissection. And sometimes if you're not very clear, you can keep them on table for like 5 minutes, even 10 minutes. Do an angiogram. If it's still behaving, you can DCB at that point. One crude way of measuring is once you've done the lesion preparation. Sometimes, of course, it's not going to look pretty. When you look at that lesion, if I've seen this lesion at the beginning, would I do anything, to this lesion? And if you think like, no, I wouldn't touch the lesion if this is how it was at the beginning, that's one crude way. FFR more than 0.75 or more than 0.8 is also acceptable. So check deliverability. Most diseases are a little bulkier than stents, so use your NC balloon to go up and down. And if it's okay, you can deliver under 2 minutes and minute or more. And then the DCB at nominal pressure for 30 to 60 seconds, only to deliver the drug, and 5 millimeter longer than the balloon areas to avoid geographic miss. It will not look pretty. That's the biggest hurdle we have, the interventionist, in our minds. We feel very uncomfortable to leave a non-pretty looking, non-stent-like looking lesion without covering and walking out of that lab. That's the biggest hurdle for us. But we are not in a beauty saloon. We should look at the mid-term, long-term outcomes. Stent looks the best on the day that it is put, but the DCB looks better as time goes on. Dissections, really need to learn our dissections, coronary dissections again. NHLBI criteria is what we use from A, B, C, D, E, F. A is just haziness. B is like a parallel line like a tram line, but the dye clears. Type C is there's contrast hanging. Cover them with a stent. Stents are our friends. We should use them for what they were invented for, that is to bail us out if there is significant recoil or if there's a vessel-threatening dissection. Type D is a spiral dissection, needs covering. E is a contrast filling defect. F, vessel closure. This is a type B coronary dissection. If you see at the sorry. If you look at the proximal LAD at the sorry, it's not on loop. You can see it here, yeah, at the bottom of the wall. There's like a parallel line. That's a type B dissection. There's no dye hem. We DCB'd, and actually we brought him back in 5 months to do another vessel. And you'll see how it's nicely healed up with nice vessel remodeling. This is a type C dissection. You can see some contrasting it from the previous injection as well. So this should need covering with the DCB. Some people can try to convert this back to a type B by using cutting scoring balloons. I wouldn't recommend it, especially at the early stages. And this is a spiral dissection, of course, needs covering with a stent.